Good evening, friends. I am Dr. Sandeep Agarwal, practicing as a consultant endocrinologist at Science City, Ahmedabad. So, today I'll be discussing about important molecule insulin Degludec, which is an important molecule for all of us because this is a molecule we have in our armamentarium for the management of type 1 and type 2 diabetes. So, we'll be discussing about this molecule in the OPD setting and IPD setting. This meeting has been commercially supported by Novo Nordisk, and I have no actual conflict of interest in relation to this presentation. Now, I'll be discussing a case scenario. Mr. Ajit, he is a 45-year-old engineer who is overweight and is hypertensive. And when we talk about his medical history, he is having type 2 diabetes for the past 6 years, hypertension for the past 7 years, and he has significant dyslipidemia for the past 2 years. He has a history of alcohol intake, more than 2 drinks per week. He is non-smoker and he is very irregular in his exercise habits. There is family history of diabetes. When we look into his biochemical profile, his HbA1c is not in target range, it is 9.2. Fasting and post-meal glucose is elevated, and there is no history of hypoglycemia. And there is significant dyslipidemia, and his eGFR is low, 55, which is stage 3 renal failure. And he has been diagnosed with increased ASCVD risk and has microalbuminuria. You can see 200 milligram per 24 hours. And he has been advised for healthy diet, regular exercise and maintenance of ideal body weight. So what are the challenges in previous medications? So there is a treatment history of antihypertensive medications, statin therapy, cardiac therapy, and along with the oral anti-diabetic agents. So he is on full dose metformin 2 gram per day. He is on injectable liraglutide 1.2 milligram per day, on empagliflozin 25 milligram per day. But still the challenges are his glucose is uncontrolled and he has a very hectic lifestyle, and he is fearful of taking insulin, because he is traveling often and is unsure about whether he will be able to take insulin on time or not. So what does ADA say about initiation of any injectable therapy or insulin therapy? So ADA latest guideline says that if you want to start any person on injectable therapy, please start them on either GLP-1 analog or combination of GIP or GLP-1 analogs in most patients. And if the patient is still not reaching target, then start them on basal insulin. Now, what are the features we should see in patients who ideal features of basal insulin? So ideal feature will be it should be flat, peakless. So there should not be any peaking effect, right? And there should be minimal variability. You can see that in the second picture, minimal variability, and it should have long duration of action, more than 24 hours. So this slide I have added, and you can see that if you use a basal insulin with a shorter half-life, let's say 6 hours, so there will be a lot of peaking effect. This is not what, yes, it is working. So there is a lot of variability in the first, you can see, and if the half-life is 12.5 hours, there is less variability, but still variability is there. And if the half-life is very long, like 24 hours half-life, then the variability is lesser. And what if you miss the insulin dose who has shorter half-life? So there will be some trough effect will be there, and there will be minimal insulin levels leading to hyperglycemia. And if the half-life is intermediate, 12.5 hours, and if you miss the dose, then there will be lesser insulin dose in circulation and there is a risk of hyperglycemia. And if there is 24-hour half-life insulin you use, and if you miss the dose, then the significant hyperglycemia may not be there. And what if you give the double dose of insulin? So in this picture you can see that there will be risk of hyperglycemia because the insulin level goes up, right? Intermediate insulin dose, so there is still some amount of hyperglycemia. And if you give double dose of long-acting insulin, there won't be much change, and the risk of hypoglycemia is lesser. So now we'll see what are the evidence-based review of basal insulin in outpatient setting. So you can see that Degludec has a very long half-life of more than 42 hours. Glargine U300 has 22-hour half-life, and U300 has 36 hour half-life. And this is a trust study. So in this, 1000 patients were taken of type 1 and type 2 diabetes. This was a prospective, non-interventional, post-authorization safety study, and the patients were followed for almost 12 months. So what we can see that at the end of the study, there was significant reduction in HbA1c to the tune of 1.8%, and fasting glucose also decreased by 64 milligram per deciliter at the end of the study. When we look into the within the glycemic variability, when we compare with Degludec with insulin glargine U100, this is a two euglycemic clamp study of type 1 diabetes comparing Degludec with U100. You can see that proportion of area under curve glucose in range with Degludec is consistent throughout the day from 0 to 6 hours, 6 to 12 hours, 12 to 18 hours, and 18 to 24 hours. And when you look into U100 with the similar dose 0.4 unit per kg per day, you can see that there is a tailing effect, and the effect goes down as the day goes up. Now, when you talk about within day glycemic variability with U300 compared with Degludec, so again the consistency is maintained with Degludec, but with Glargine 300, initially there is a spike, there is some peaking effect is there, and the risk of hypoglycemia is there with U300, and then there is some downward concentration of U300, and then again picking up. So within day glycemic variability is up to 40%. Now when we talk about day-to-day glycemic variability when compared with Degludec with U100, you can see that there is lot of variability, and there is but with Degludec there is no variability. With Glargine U100 there is lot of variability. And when we compare Degludec with U300, again we see lot of variability, day-to-day variability there compared to Degludec. Degludec is showing no variability or minimal variability. This is a switch pro RCT study. This is a continuous glucose based monitoring device done with CGM, continuous glucose monitoring based device study. And we can see that patients were taken and they were divided into two groups. Half were given Degludec, half were given Glargine, and then after 16 weeks the patients who were on Glargine were switched to Degludec, and the patients who were on Degludec were given Glargine. So what we can see that patients who were switched from Glargine to Degludec, they had increased time in range by 20 minutes per day. That translates into 1.4% additional time in range in Degludec group, and there was significantly lesser nocturnal time below range with Degludec. Again, we can see from different studies, this is a across RCT and real world evidence in more than 16,000 patients. So we can see that different trials like Begin trial, phase 3A, phase 3B, Switch 2 trial, CVOT, Devote trial, and real world evidence, European Treat type 2 diabetes. So we can see that in all these four trials, there is nocturnal and severe hypoglycemia was lesser with Degludec compared with Glargine U100. And the nocturnal hypoglycemia was as low as 90% in real world evidence. Now coming to confirmed study by Degludec et al., you can see that 4,000 patients of type 2 diabetes were taken. They were on insulin naive, and they continued treatment for 6 months. And it was seen that as compared to U300, there was 30% lower rates of hypoglycemia with Degludec compared to U300 Glargine. And there was significantly lower proportion of patients experiencing more than one episodes of hypoglycemia with Degludec compared to U300 Glargine. Now, what about flexibility? So, many patients are not able to take insulin on time. So, with Degludec, there is flexibility of 8 to 40 hours. Whereas with Glargine U100 there is no flexibility, and with U300 there is flexibility of 3 hours. So you can give Glargine, Degludec at a variable period, but ideally you should give at same time. So about potency, Glargine 300 has 30% lower potency compared to Degludec. We can see from this area under curve. So Degludec, we can see that mean area under curve glucose in range, it is 1913. With Glargine it is only 1300. That is statistically significant. Now another study by Phyllis et al. Bright RCT. This is again Degludec versus Glargine U300. This is a multi-centered, open-label, parallel 24-week non-inferiority study in insulin naive patient with type 2 diabetes. So what we can see that almost 500 patient, 1000 patients were taken into the study. Half were given Glargine, half were given Degludec, and the idea was to check for fasting glucose, and target was 80 to 100. So you can see that lesser dose was required for Degludec compared to Glargine U300, and there was better fasting glucose control with Degludec with lesser insulin dose. Now what about RSHDI guidelines? So RSHDI guidelines 2022 says that Glargine U300 requires higher dose. So we have to give 20% higher dose compared to Degludec. And ultra long acting insulin analogs in inpatient practice. So till now we saw the outpatient practice. So inpatient practice, what is the evidence? So the onset of action, as we all know, with Glargine it is 2 to 4 hours. And Degludec, it is faster onset of action. It starts acting as early as 30 minutes after injection, and U300 is even slower. It is 2 to 6 hours. So this was a Degludec hospital trial comparing U100 Glargine with Degludec U100, and it was seen that Degludec was non-inferior to Glargine U100, and Degludec achieved faster glucose control as early as 1 day. And we all know that target glucose in hospital patient is 140 to 180. Now ease of daily titration. So usually we don't titrate daily, we titrate every 3 to 4 days. So, but with this study like efficacy and safety of Degludec U100 and Glargine 300 in post-op management of CABG patients by Shafikuchi et al. So it was seen that daily titration of these long-acting molecules are possible, and it was safe. Again, in Degludec hospital trial, it was seen that daily titration was safe and effective with lower rate of hypoglycemia. This was again another study, EDIOS study, in which 65 patients were taken, and it was seen that there was significant reduction in fasting capillary glucose achieved with Degludec. So you can see that Degludec 36 milligram per deciliter reduction with Degludec compared to Glargine U100, it is only 15 milligram per deciliter. Now regarding efficacy, again by Shafikuchi et al. So it was seen that the fasting was significantly better controlled with Degludec compared with Glargine U300. Now what about variability? Variability in this Simuni et al. They have shown that at admission the variability was very high, sometimes 100, 200, sometimes 400. So the standard deviation was very high, but at discharge the variability came down to 100 to 200. Now Degludec low variability Indian patient data by Shafikuchi et al. So we can see that 70 to 140, again the more percentage of patients with Degludec achieved 70 to 140, 43%, and 100 to 140 more percentage of patient 37% achieved 100 to 140 compared to Glargine U300 only 34%. And time in range, as we all talk about 70 to 180, so 74% of the patient achieved time in range by Degludec compared to Glargine. Now again EDIOS study in which 65 patients were taken. So patients were on Glargine and Degludec, and the patients who were on Glargine, they were switched to Degludec. So total number of patients who were on Degludec was 35. So what was seen in this study was that patients who were on Degludec, they had 20% of the patient had hypoglycemia, whereas on patients who were on glargine, they had 26% of the patient had hypoglycemia. And the patients who were switched from glargine to Degludec, so pre-switch the hypoglycemia was 25%, and after switching to Degludec, the hypoglycemia reduced to 15%. Now, lower risk of hypoglycemia in inpatients. So again, in this Shafikuchi study, we can see that hypoglycemia, so level 1 hypoglycemia, glucose less than 70, it was with Degludec it was 15%, with glargine U300 it was 23%, and severe hypoglycemia less than 54, it was lesser with Degludec 1.6% and 4.3% with U300 glargine. So Degludec is approved for use in pregnancy, pediatric patients. We are all using in type 1 diabetes, elderly patients, adults, and patients with hepatic or renal impairment. And it can be used in almost all patients. And it is the ideal insulin because it has a long half-life and it is peakless and it has minimal variability as we have seen, and it has long duration of action. So the flexibility of injection is always there. So if somebody is not able to inject in the evening, they can inject in the lunch time or some other time. So 8 to 20 hours flexibility is there. So I would like to thank you all for the patient hearing and would love to take questions if any.